performed to evaluate for infection. In fact, cell count should be ordered on every acidic fluid specimen, even if you're just performing a therapeutic paracentesis and draining that tense abdomen, for example. The diagnostic criteria for SBP includes a positive ascites fluid culture and neutrophil count of greater than 250 per milliliter. At Sketchy, our recurring symbol for neutrophils are neutro first responders, since neutrophils are like the EMTs of the immune system. Notice, too, that the oil canister thingy is that ancient Roman medicine or something? Whatever. It forms the shape of the number 250. For more information on SBP, check out our cirrhosis complications and management video. Next up, heart failure. Assess for the typical clinical manifestations. Remember, ascites in this case is being caused by fluid overload. If heart failure also involves the right heart, hepatic congestion factors in as well. Signs of heart failure include peripheral edema, as well as pulmonary edema, which presents with orthopnea, dyspnea, crackles on exam, and fluffy opacities on chest x-ray. Additionally, look for elevated jugular venous pressure, which directly correlates with elevated central venous pressure. That translates to elevated portal pressure, the cause of ascites. Underneath our symbol for causes of right-sided heart failure, let's put a busted valve. In patients with right-sided heart failure that involves significant tricuspid regurgitation, the liver may be pulsatile due to the backflow of pressure into the hepatic venous system with every contraction. Also assess for hepatojugular reflux. This is performed by pressing firmly on the liver and inspecting for distension of neck veins. In general, reflux will be present in the setting of cardiac causes of hepatic congestion. In cirrhosis and Budd-Chiari, this sign will not be present. Another way to distinguish liver causes of ascites from cardiac causes is to check that old BNP, the tried and true marker of ventricular overdistension. For more details on the clinical manifestations and diagnosis of heart failure, check out our dedicated sketches in the cardiology unit. Let's wrap up with Budd-Chiari syndrome. In patients with acute Budd-Chiari syndrome, symptoms develop over a few weeks. Expect to see severe right upper quadrant pain, hepatomegaly, jaundice, and ascites. Variceal bleeding may occur as well. On labs, elevation of serum aminotransferases occurs due to ischemic hepatocellular damage from vascular congestion. Budd-Chiari can also present with acute liver failure, which is characterized by massively elevated transaminases, jaundice, hepatic encephalopathy, and an elevated PT-INR. We'll symbolize liver failure with this crack in the liver. For more on the clinical manifestations of acute liver failure, check out our liver failure sketch. Well, that's it for the major portal hypertensive causes of ascites. Let's move on now to the differential for non-portal hypertensive ascites. Remember, SAG will be less than 1.1 here. Again, let's organize the causes by the paracentesis findings. First, nephrotic syndrome. Ascites occurs due to loss of protein in the urine, which is depicted here by this frothy, proteinaceous leak from this kidney pot. This leads to a decrease in plasma oncotic pressure. Leaky abdomen, here we come. The protein concentration in the acidic fluid will be low, less than 2.5 grams per deciliter, in other words. So again, we've brought in that protein vase and positioned the leaky kidney below. Patients with nephrotic syndrome typically present with periorbital edema and prominent bilateral pedal edema, which may progress to anasarca. Patients may also have frothy urine due to high levels of proteinuria. Patients with nephrotic syndrome have a protein level in their 24-hour urine collection greater than 3.5 grams, and patients usually undergo a renal biopsy to determine the specific cause. For more details on the clinical manifestations and diagnosis of nephrotic syndrome, check out our dedicated sketch in the nephrology chapter. Ascites can also occur in the setting of pancreatitis, which at Sketchy is always depicted with a leaky pancreas sponge. It most commonly presents in patients with chronic pancreatitis secondary to alcohol abuse, though it can also occur after an episode of acute pancreatitis or following traumatic injury to the pancreas. The pancreatic fluid that accumulates is protein-rich, so expect an elevated acidic fluid protein concentration greater than 2.5 grams per deciliter. Additionally, you'll find an elevated level of amylase, typically greater than 1,000 units per liter. To depict amylase, we've drawn in a slobbery, amylase-ridden dog tongue. Dang, that's gotta feel good. Exfoliating. Once the diagnosis has been established, An abdominal CT should be performed to evaluate for a pseudocyst. ERCP may also be performed to localize the site of leakage and to perform endoscopic therapy. Ascites can also occur in the setting of malignancy, including cancers of the ovary, breast, colon, lung, pancreas, and liver. The diagnosis of malignancy-related ascites is based on the clinical setting, imaging tests, and acidic fluid analysis. It should be suspected in patients with a known malignancy or in patients who have lost a large amount of weight before the development of ascites. A variety of underlying mechanisms can cause the ascites in the setting of malignancy. Peritoneal carcinomatosis can occur, for example, a process by which cancer implants on the layers of the peritoneum and omentum. Depicted here by this cancer crab symbol stamped on this Roman dude's omentum. These cancer implants can subsequently cause an exudative ascites. On paracentesis, expect to see lots of protein, which is why we've placed him in the bath above our recurring protein vase symbol. You'll also typically see an elevated white blood cell count, which can actually look like SBP. The tip-off that the fluid is not infected is the predominance of lymphocytes as opposed to neutrophils. So, instead of neutro first responders, we've drawn in our recurring symbol for B cells, white antibody archers. Cytology for malignant cells should be sent on all acidic fluid samples from patients suspected of having malignancy-related ascites. The overall sensitivity of cytology smears for the detection of malignancy-related ascites is 58 to 75%, but will really only be positive if peritoneal carcinomatosis is present. On paracentesis, the acidic fluid sample may be turbid or cloudy due to the presence of cells, or sometimes even bloody. Keep in mind, however, that there are other ways for the cancer to cause ascites without implanting on the peritoneum. Primary hepatocellular carcinoma, or secondary mets to the liver, for example, can cause portal hypertension with ascites. The acidic fluid sample will be pretty standard for a portal hypertension etiology. High SAG, low protein, and an otherwise minimal amount of cells. You're most likely to have a negative cytology. No malignant cells detectable, in other words. The appearance of acidic fluid in the setting of malignancy in the liver is often bloody, however. All right, let's sum up this saggy bathhouse into the important categories. A SAG greater than or equal to 1.1 indicates ascites due to portal hypertension. A SAG over 1.1 and a low protein count is characteristic of ascites due to cirrhosis. Expect pale yellow fluid. SBP is characterized by a positive fluid culture and a neutrophil count over 250. Remember that cancer in the liver can also cause portal hypertension and ascites with high SAG and low protein. A SAG over 1.1 and total protein over 2.5 is characteristic of the cardiac causes of ascites. Budd-Chiari causes venous congestion and portal hypertension, so it's also associated with a SAG greater than 1.1. The total protein count is variable depending on the level of liver injury and portal hypertension. A SAG less than 1.1 means something other than portal hypertension is causing the ascites. Nephrotic syndrome causes ascites secondary to albumin loss in the urine, which decreases intravascular oncotic pressure. Expect the ascites fluid to have a total protein less than 2.5. Etiologies with a low SAG and elevated total protein include pancreatitis and peritoneal carcinomatosis. Acidic fluid analysis in the setting of pancreatitis will typically reveal elevated amylase. Peritoneal carcinomatosis will typically present with cloudy acidic fluid and lots of protein and lymphocytes. Malignant cell cytology is positive in a majority of cases. Oh yeah, that allose though. Let it blow, son.